Hello, good evening, viewers, and welcome to your favorite medical show, Ask Dr. Saw. Tonight, as usual, we're coming to you live from TBN Studios right here in Queenstown, Georgetown. As you know, the format of the show, we do half an hour of educational, informative programming, and then in the other half an hour, we are going to be taking your questions from last week. We have quite a few questions from last week, so we'll be taking those questions. Joining us as usual, and the man that makes all of this possible is Dr. Saw himself. He's in England. Dr. Saw, good evening to you.
Good evening, Akash, and yeah, thanks for having me again.
Great. You know, Doc, this show has been it has been garnering a lot of viewership, and the interactive part of it really makes me feel good about it because we're getting the message out there, and people are also sending their messages to us, so they also can have their medical conditions, have some opinion on it, and given some ideas as to what they can do. Last week we were dealing with headaches, and this evening we are going to be dealing with and even we're going to be zoning in on migraine headaches this evening. So, and we have, as I said, we have a lot of questions from last week, but we'll do that in the second half of the program. So, Doc, again, thanks so much for joining us, and let me start off first by asking you, what is migraine?
Okay, Akash, before I just want to make a comment on what you said earlier about the show and the intention, really. So
Yes.
I like the interactive nature, that is one. And one of the things that prompted me to do this show actually is that patients all the time come in to see the doctor, and they will come, many times, sometimes for the same problem. Mm-hmm. And I realized that it is not about, during the consultation, you spend 15 minutes or so with the patient. I mean, in the UK, we spend 10 minutes with the patient allocated time, but of course we go over that. And because there's so much to talk about or to go through, patients don't really take everything on board, and they probably only absorb about 20% of what you say to them.
Okay.
And I feel that by doing a show where we can give some clarity as to symptoms and diagnosis and medical conditions, patients can go back and look at it and have some clarity, and some of the questions, can be answered in that way. Because of time constraints and lots of other factors, sometimes you can't do it in a proper consultation on its own. And there's so much of knowledge out there on the internet that you don't, it's hard to dissect. So I try to condense that. But yes, come back to your question. Today we're talking about migraines, and the question is, what is migraine? If you recall last week, I talked about migraine disorder as a complex type of disorder where there is a sensation of pain in the head, sort of within the head, there's a sensation. And I said there is over 100 different types or association of headaches. So almost everything. If your light is too bright, you get a headache. If you're hungry, you get a headache. There are so many causes. But migraine is a specific entity that is described as a recurrent episodes of headache. So we would describe it as a primary. So when we talk about primary headache disorder and we talk about secondary headache disorder, we talked that primary headache is it's caused by some headache mechanism, whereas the secondary headache is caused by another condition where headache is a manifestation. So now, migraine is the second most common primary headache disorder. The first one was tension headache we talked about last week.
Yes.
Now migraine is the second most, and it's common. So the definition really is recurrent episodes of headache, and in between attacks, you are normal. So that's the kind of nature of the migraine, and I will go through to describe, how it presents and what are the things to look out for. But just some little overview. It is more common in female than males. There is a genetic predisposition, so it runs in family. They say majority of it, about 80% of migraine present under the age of 30. Mm-hmm. And over the age of 40, the incidence prevalence start to decline. So it would be unusual for somebody at 50 or 60 to come and say, Doc, I've got a headache, and I make a diagnosis for the first time as migraine. You always want to look for some of the more dangerous causes of headache, like bleeding in the brain, tumors in the brain, in those category of patients. But there are some salient features of migraine that we need to talk about that distinguishes it from other types of headache.
Right. Doc, just to interject here, based on some research I was doing, one website that I was reading from, they said migraine affects about 1 billion people.
Globally, probably close to that. Globally, the stats that I have says that it's about 10% of the global population.
Okay.
So, fine, how many we've got in the world?
About
8 billion?
8 going on to 9 billion or something like that. Yeah, I think.
Right, so you'd be
Yeah.
close to that if you say 10% and just over 10%. We talk about 1 billion people.
Wow.
So it is indeed a common, it's a common thing. And but thank God, lots of the headaches are manageable with simple over-the-counter stuff.
Mm-hmm.
But there are times when headaches can be so disabling, migraines can be so disabling that you stay home for days.
Right.
So you can't function, you cannot do what we call activities of daily living, and you cannot function in your job. Now, that costs the economy millions, if not billions.
Yes.
Yeah? So, it is very a big topic, and that is why I think I couldn't do justice to migraine if I were to talk about it in the general grand scheme of headaches on its own, because it is so quite, it's prevalent and it causes lots of disability.
But Doc, let me ask this. In the interest of time also, what causes a migraine headache? And for instance, some people would say, like, you know what, I went out already this morning, I was in the sun, and I get a terrible migraine headache, or I go outside and something happened, I see an accident, I get it. What triggers this?
All right. So there's there are two different things there, right? So yes, you go out in the sun and you have a migraine, let's say. But do we think that the sun is causing it?
Absolutely
Because
not.
everybody else in the sun, and they did not get migraine. So when we talk about cause effect, we are talking about this is the cause. But no, migraine, the cause is really more of a scientific, biochemical thing that is happening in the body.
Mm-hmm.
So there is a theory called a neurovascular theory.
Right.
Where there are some changes in the blood vessel and the chemical in the brain that cause increased sensitivity to certain receptors in the brain, pain receptors that give you migraine. So when we talk about it, so that is the pathology or the cause. We call it, in medicine, we call it etiology, the cause, the pathophysiology. What happened internally in the body that's giving you this headache?
Right.
Now, so we know it's a vascular chemical. So what tends to happen? The chemical triggers in the brain cause the blood vessel to get different size. It fluctuates in size. So we have vasodilation, vasoconstriction. So the size of the vessel changes, and all these pain receptors get activated, and you get manifestation of pain. So that is the cause. The conditions that you're talking about that are like the sun, we call those triggers, right? And triggers can be anything. You can be hungry, and that's a migraine trigger. Mm-hmm. You can have emotional stress. That's a migraine trigger. Heat, the weather, there's so many, almost everything. There's certain food.
Yes, certain scents, right? You can smell something and it triggers a migraine.
Absolutely, yeah. Light, exhaustion, exercise, all those things are triggers. And of course, in the way I tend to ask patients lots of times for them to get a headache diary. And one of the ways of managing headache is to get that headache diary. One, it helps in the diagnosis because there's so many different types of headache. So what I would say, okay, tell me, you would write down when the headache starts, when it stops, what you were doing, what are the things, what did you eat before, what were you, were there any circumstances going on in your life, but when the headache came on, have you had an argument and then the headache started? Did you travel for a long period and come back and the headache started? So these are all triggers. And once you have that headache diary, it gives you the time of the headache, it gives you the duration of the headache, it gives you what we call associated symptoms. Because classic migraine, in the definition of migraine, so we wanted to say now, how do we say this is migraine? So
Right.
what are the salient features of migraine? So they say migraine can last between 4 hours to 72 hours. So think about it. So it's a recurrent episodic headache that can last between 4 hours to 72 hours. So patients can get a headache that lasts for 3 days.
Yes, I've heard that before.
Absolutely, and even longer than that. So there is another definition. If it goes beyond that, you can have what we call chronic headache. If you get a headache more than 15 days in the month, we say this is chronic headache. And that can be also as a progression of migraine. We have chronic migraine as an entity has also been classified. All right, so let's look at some of the salient features. How do we distinguish that this is migraine? So the characteristic of the headache is very important to tell us this is migraine versus other forms of headache. So one, it is unilateral, so most times, but remember they're all variants, and I'll talk about that in a minute, but we're looking at your classical migraine. So your classical migraine is unilateral one-sided headache, so the headache is one-sided. It is pulsating or throbbing. So a patient to come to us and say the headache is pulsating or
they feel a beating in the head. Yes.
Absolutely. And it is moderate to severe in intensity. So this is not your, dull little ache in the background. This is a headache that becomes a little bit debilitating. It affects you from doing things. And it is aggravated by head movement or by movement. So you walk up the stairs, your headache might get worse. You move around the house and do chores, your headache may get worse. So those are, they say if you have those symptoms, if you have two of those characteristics, we say that is, it's possibly migraine. And then if you have one of two other features we talk about, so two of those four, and then one of either worsen with light or noise, or associated with nausea and vomiting. So if you get worsen with, so those features, two of those features, unilateral pulsating and severity and head movement, and then it is aggravated by light or noise, or it is associated with nausea or vomiting, either one, you can say classically, I have got migraine.
Right.
What is called migraine without aura. So there is some stages of migraine that is well established and well documented. So you have something called prodrome, like any disease. Before you get a flu or let's say chickenpox or any infection, you get what we call a prodromal period where you feel a bit tired, you feel a bit weak, and then 2 or 3 days after, then the rash comes out, and that's your symptom. Your sign or symptoms, right? So the prodrome is the thing leading up to your condition. So there are patients who can have prodromal period in migraine where they have a period where they have mood changes. They may have loss of appetite. They may have sensitivity to something, light, noise, whatever. So that is called the prodrome. And then you have, and these things can happen, hours to days before the migraine itself.
Okay.
So at this point, there's no headache. There is all these little bits. And then you have aura. There's something described as aura. The aura you'll get just before the headache or with the headache. It can come alongside the headache as well, right? Whereby you have, so the aura is usually described as some sort of sensory presentation. So either visual, so you tend to have flashing lights.
Okay.
In your, or what we call scotoma, like blind spots.
Yes.
So commonly patients will come and say, Doc, before this headache started, you mentioned that the smell and those things that you have, those are sensory stimulus. reception, and then you would have that blind spot. You would have that flashing light. You may have color zigzag lines in your field of vision. So that's called your aura. Or some patients come in with numbness in their body. You would have weakness or numbness in parts of your body, and that is called the aura. And then you have your headache features that I described, and then you have the resolution that can take, you can feel lethargic or sleepy as a resolution after the headache proper finishes.
Right.
Now, when you look at those descriptive terms and how it is, I think most of the time you can diagnose it yourself.
Yeah. But are there? I mean, look, I remember I remember a friend of mine. He said he had headache, and they had to take this they had this little clock in the room on the wall, and they had to remove it because him lying on the bed, he can hear every tick from the clock, and he said every time that tick, he hears that tick, it's like somebody's hitting him with a hammer.
Right. Yeah.
So, but how can you?
Sensitivity.
Yeah.
To noise. Yeah.
Yeah, but how can you test? Are there tests out there, doc, for migraine? How can we test to know whether it's? I mean, these are the classic symptoms indeed, but are there tests, medical tests that can be done?
So generally speaking, in the real world, there are lots of research being done where you can have certain brain scanning, where they give traces to see which part of the brain is active. They will look, but these are all research things being done. But the answer to that in the public domain, there's no test for migraine. But of course, you know that if you go to the doctor and you say, I've got a headache, and he's not sure what's going on, we always would say, okay, I don't know the nature of your headache. It's not classic of what I can describe, but I can, say for sure that it is something, but I will do a scan of your brain. So lots of people think that, okay, a scan of the brain will tell me if I have a headache. The answer is no.
Yeah.
The brain scan is not to tell you if you have got migraine or not. The brain scan is to look out for other causes of headache. That is brain tumor, bleeding, or something going on, infection, inflammation, whatever in the brain that is causing your headache. But primary headache, cluster headache, tension headache, migraine headache, there's no tests that a brain scan will tell us, right, this is migraine. But in the research world, of course, research is being done all the time, and we know that certain parts of the brain are activated, so it lights up. So if I were to put some tracer in the brain, in the blood, and then do some scan, I might see certain parts are more active. I might see the blood vessels a little bit different, the sizes of the blood vessel, all that. But those are not things that we will do for patients. They are all research to understand how migraine, how it is happening and how can we better manage it. But no, there is no test to tell you migraine. The features alone, the history tells you this is migraine. And as a matter of fact, the guidelines, in all the national guidelines around the world, as far as I know, it says that a diagnosis is made by the history.
Right. Yeah.
You don't need a test to make a diagnosis. They say, as a matter of fact, they discourage scanning of the brain if your history is classic.
Right,
if
exactly.
you come to me and say, I've got this nature of the headache, it's worsening with light, it's worsening with noise, I've got aura, I smell or see some zigzag lines before the headache starts, come on, that's your diagnosis.
That's right, exactly. You know exactly what you're dealing with. But Doc, how dangerous though is a migraine headache? How could it be fatal?
Usually not. Well, no, I wouldn't say it is fatal, but there are some people who they say the migraine increases your risk of stroke.
Okay.
Ischemic stroke. So, there are bleeding stroke and there is that ischemic stroke where there's a blockage. So they say migraine increases the risk of stroke. Migraine can also increase your risk of depression and mental health disorder.
Exactly, yeah. And that's when people start getting suicidal and all of that.
Absolutely. So in terms of, is it dangerous? Of course. It can be dangerous if it affects your daily living, your life, your whole general perception about yourself and your environment. if it has a toll or impact, and that way it can be dangerous for you. Patients, get suicidal. But there are some different types of headache that I just want to touch on that can be very significant and can be classified as, sort of dangerous in the eyes of patients to say that, fine, paralyzed, and that's a manifestation. So there is something called hemiplegic migraine. So there are different different classification of migraine. So we talk, classically what I talk about is your classic migraine with and without aura. That is, without all these things like flashing light and sensory stimulus. But you have the hemiplegic migraine where patients present like a stroke. They get one-sided of their body weak. They have different sensation in one side of the body. They're, like paralyzed. Wow. And we call it hemiplegic migraine. Because when you look, of course, if they present like that, we're not going to say, all right, you've got migraine and give you migraine tablets. If you present like that, I would first ensure you have a scan of the brain, rule out that you don't have a stroke. And if this is a recurrent nature associated with a headache, then I'll say, fine, this is your hemiplegic migraine. And then there is another type of migraine, ophthalmic migraine. So ophthalmic migraine, you can have visual symptoms where you are blind. You can have momentarily get blind, one-sided, or you have absent of part of your vision is gone. And then you have ophthalmoplegic, which nowadays they don't call it, in the old days, ophthalmoplegic headache. Now they say it's a nerve problem, really, neuropathy. So the ophthalmoplegic headache, you get paralyzed in the eye, muscles of the eye. So your eye may drop, you may have thing, and then the eye pupils, you see it's a different size from the other one. And so you have lots of eye symptoms. So that's the ophthalmoplegic, and then your retinal headache, hemiplegic. So those are your kind of variant. And they have some migraine, which we have some migraine-associated syndromes. There are patients who have a type of cyclical vomiting or abdominal type of migraine, they call it. So this is sensitivity of their stomach, and they have associated with migraine. They have episodes of vomiting for no known cause.
Yes, yes.
So these are, that's your cyclical vomiting type of syndrome.
Right, because...
So there are loads of different, cyclical vomiting syndrome, abdominal type of migraine, hemiplegia, So migraine doesn't have to be your classic migraine, but there are different features. But the important thing is that we have to, whenever you have some of the atypical presentation, you have to ensure that there are no other cause to explain that. And then you could blame it on an organic type of migraine because there's no test to establish that.
Okay, great. Doc, we got just over 5 minutes remaining for this first episode. What I would like to ask, is about treatment, because look, as I said, there's so many people out there with migraine, and lots of people can't go to work. When they go to work, they can't function. Migraine can be excruciating, but it can be punishing in many ways.
No, absolutely. And I said to you, thank God, majority of the headaches can be managed effectively, but there are lots of patients who I have who would come with debilitating symptoms, and your traditional painkiller is not going to work. So, okay, I want viewers to understand two concepts in migraine management, and this is very, very important. So, when you have a migraine, there are two ways to manage it. You want to manage that migraine at the point of time when you're having it. And that is called management or abortive treatment. You want to abort the headache.
Right.
So you get the headache now, you want to abort it. You want to stop it in its tracks. Right? And that is called your acute management. And the next thing is something called preventative or prophylactic management. So there are two concepts in the management. So one, you have a headache, you want to treat it right away so it disappears. But if it disappears, fine, and it is coming every day or every week, then you want to take something to prevent you from getting it. So it's like you have a heart attack, and I treat your heart attack, I put a stent in, or I give you whatever it is at that point. But also I want to prevent you from getting a heart attack. I then treat your blood pressure and your cholesterol and your diabetes.
Right.
Do you understand that analogy?
Exactly, yeah.
So similarly, when you have an attack, we want to treat it acutely. So let us start quickly, because limited time. So let's talk acute management. Acute management, traditional painkillers you would start with. So your paracetamol, your ibuprofen, your aspirin, that is your traditional first-line treatment. So in patient, if I take paracetamol and it works, then fine, that is good enough. If the paracetamol doesn't work, I take ibuprofen, I can juggle them, I can put them together. But importantly, in the acute management, there are times because you feel nauseous and your stomach is all upset, sometimes the drug doesn't work, and we sometimes give anti-sickness medication with the painkiller. So your paracetamol, your ibuprofen, your aspirin, you add anti-sickness medication, something like metoclopramide, domperidone, or cyclizine, or chlorperazine. These are all anti-sickness medication with your painkiller. Now, there's some newer drugs now specific for migraine. So paracetamol, ibuprofen, aspirin, they're normal painkiller, works for any pain. Mm-hmm. If your migraine is mild, then of course that can work. In lots of patients, that can't cut it. So they need something specific for migraine. And there's a family of drug called triptans.
Right.
So that has been around for years. And that is a specific drug now. We then go the next step up. So if you're not controlled with your normal paracetamol and ibuprofen, then we go to the triptans. And some of the names would be sumatriptan, zolmitriptan. There are different types of triptan. There's a whole big family of it. Now, that you will give in the acute attack when you get a headache. You'll give one, then if it doesn't subside, 2 hours after, you repeat the dose. If you find the small dose doesn't work, the force dose, sometimes we double the dose. But there's a limit as to how much you can use, depending on the type of product. We will tell you that. It can cause tightness in the chest, so patients should be aware of that, because that's the type of mechanism how it works, or tightness in the blood vessel. And there's some other one called orgotamine derivative. So these are specific for migraine. In the past 5 years or so, just about around there are some newer drugs came out called GPANs, a family of drugs. And I look at the data, and they're very effective. GPANs. So in the past few years, I would tell patients who are not getting better with normal, conventional, or the traditional way of managing it, we have some newer drugs in the market now that are very effective, and they are safe. They have been studied, and trials have been done on them, and they're very effective. So that is for your abortive acute management. Quickly, what we got, about 2 minutes?
Yeah, we got about 2 minutes, yes.
Yeah, exactly. Quickly on to the preventative treatment now. So when you have so they say if you're having more than 4 attacks a month, you should go on preventative treatment. Or if that migraine is lasting for 2-3 days, if it is debilitating, you should go on preventative treatment. So what are the preventative treatment? There are loads of it. So classically, there's a drug called beta blocker, family of drug called beta blocker. They are used for the heart and blood pressure problem. I don't know if you've heard of a drug, propranolol. So that's a commonly used one. So the family of beta blocker as a prevention. So prevention you have to take every day.
Okay,
right?
Okay, every day.
So, yeah, and then you have a couple more I will tell you about. There's one called amitriptyline. It is an old antidepressant. We don't use it nowadays for depression because there are newer drugs for depression. But amitriptyline is an old one that is still being used for prevention of migraine. Again, these drugs got to be taken every day. Mm-hmm. Then you have another drug called topiramate, which is an epileptic drug. It's given for seizures.
Right.
And that's a preventative drug. And of course, the same GPANs I told you, family of GPANs, that also have just got a few years back, got licensed for prevention as well. So we can take that. Again, you take it every day for prevention. And there's some newer therapy over the past few years. They're called immunotherapy, mm-hmm. where you're given injections as a prevention of migraine. Okay. And so that's in summary. So we touch on the classical features, we touch on the prevention, the causes, the treatment, and how do you prevent it. And of course, to prevent it, you look at triggers and you try to avoid triggers.
Well, one last thing before you go from this with the segment, Doc. Alternative treatment. Is there any horrible treatment that you know of? Any?
Yes, there are some evidence tell us that there is some horrible stuff, plant products. butterbar. Have you heard of butterbar? It's a plant.
I don't think I heard that one. Yeah.
I've never heard, but it's in alternative treatment. You have butterbar. You have something called feverfew. So these are plants extract. Feverfew. Coenzyme Q10. We sometimes give that without a treatment. That's an alternative one. And vitamin B2, riboflavin.
Okay.
Those are all your type of alternative thing. And of course, we encourage patients to have CBT, that is cognitive behavioral therapy, acupuncture, massage therapy, relaxation therapy. These are all the things. You want to do things to avoid stress because stress is a trigger.
That's right. All right, Doc. Thanks so much. This is it for this segment. We are going to be back. Viewers, we're going to be back with the next segment where we're going to be taking your questions, answering your questions from last week. Again, continue to send in your questions. I hope you're enjoying tonight's show, and we're talking about migraines. See you in a few. Hello, viewers. Welcome back. This is the segment now where we're going to be answering your questions from last week. We have quite a few questions, Doc. Some of the questions that some of them that are not exactly questions, but they were little concerns that were raised, so I put them over so that we can deal with them also, because I found that some of them may need some answer. At least I need answers for them, so myself too. Yeah. Yeah,
and it should be a discussion. I mean,
right.
and of course, if they are things, sometimes people make comments, and we can just give some clarity on that,
exactly.
And a medical perspective,
yeah.
if I can.
Right, indeed. So viewers, thank you so much for your questions again. We're loving this. So let me start with the first question. It says, Doc, I just get headache if someone come and wake me up all of a sudden.
Right. So, yeah, I mean, that is possible. I mean, headache, as I say, there are so many things that can trigger a headache. And I would say there are two components to that. So that abrupt awakening can create what we call a type of fear.
Mm-hmm.
And when you have fear, we have what we call a sympathetic drive.
Right.
Flight or fight.
Yes.
Hormone, right?
That's naturally built into us.
I am trying to just theorize here, and there is some medical science behind it. That when that happens, because we know headache is pain generally is caused by, when I tell patients how I describe pain, there are some receptors in the body picks up those pain signal, and they transfer it to the brain, and then the brain interprets it. Mm-hmm. And we said that is pain. We will describe it, this is burning, this is shocking, this is whatever it is. So those are the kind of stuff that happen in the brain. The brain processes it and analyzes it. Right. So in that abrupt sleep situation, there are some chemical factors involved, but we also know that it changes in headaches. You have some chemical that can change the size of your blood vessel. So you have, we talk about that neurovascular theory. Right. So I think as an abrupt awakening state can trigger that, and some of the receptors in the body become hypersensitive. Okay, good. And that is a trigger. That is, quite a trigger. And even patients who don't sleep well, we know can get headache. I mean, that's a common presentation. If you look at patients with sleep apnea, you have patients come in and they snore or they get blockage, right? So in sleep apnea, you have a blockage and you don't have enough oxygen, and suddenly you arouse. And the next day, these patients, they complain of headaches, they complain of, fatigue, tiredness, all of that. So that can explain it. Explain it.
Thanks, Doc. Doc, I know this person says, Doc, I know a woman who had a worm in her brains. She went berserk with a headache. She went to the USA and got surgery, and it's well now. So that's a parasitic attack she had there.
Yeah. I mean, indeed. I mean, you got worms, different types of worm, and classically we know what lots of worm. How do we get worm most of the time? We ingest eggs from contaminated food or water. Mm-hmm. It gets into the body. So these are your classical ascaris and your roundworm and pinworm and hookworm. Mm-hmm. And some of these worms, they can get their way to the brain. And one, especially tapeworm.
Tapeworm, yeah.
Tapeworm can get into the brain and they go and they form cysts. in the brain. The larva, that's a immature parts of the worm, moves up into the brain and they form cysts. Now, some of these cysts can be active, and some of these cysts can die, and it forms calcification. They calcify, and they can cause loads of neurological problems. So you can have, raised pressure in the brain. You can have seizures. You can have, lots of conditions because the brain is affected. All these cysts in these pockets of cysts, there's larva worms in them. They are distributed different parts of the brain. And they get a type of roundworm as well, especially dog and cats. Roundworm, they can also get into the brain. So worm is not just into the intestinal tract or the tummy, but this is not your classic, pinworm and stuff that you get in your bowel. These are more serious form of worm that get, moves up into the brain, gets into the blood system, and then it moves up into the brain.
Yeah, that's scary. Very scary.
It's gross when you think about it.
Yeah, just thinking about it, yeah.
Yeah, I know,
yeah.
Of course.
Next question, Doc. Doc, our body do not produce magnesium. Even though we eat foods rich in magnesium, is it safe to take extra supplements?
The answer is yes, it is safe to an extent. Now, magnesium is needed in the body for different functions. It is used for enzymes, for metabolism, for our transmission of nerve impulses and muscle contraction and all of that, right? So like calcium, magnesium, all these chemicals are needed in the body. So if you get a certain condition, so the thing is, the food we get, so we don't produce the magnesium like that, we get magnesium from the diet. The magnesium in green leafy vegetables, in legumes, nuts, peas, beans, banana, these things that are rich in magnesium. So you ingest the magnesium, it gets absorbed in the body. Now, if you have a gastrointestinal issue, you may have decreased absorption. There are patients with vomiting disorder. There are patients with, forms of gastritis. There are bowel disorder where they have stoma, ulcerative colitis, Crohn's disease. They tend to have low magnesium. And if you have, especially these patients who have stoma, you know what's a stoma? Like when they bring that bowel out in your stomach?
Yes.
Like if you have bowel problem and they cut the bowel and then they bring, instead of you pooing normally.
Right, there's a bag. There's a bag,
correct. Now, these patients, lots of times, they tend to get low magnesium. And of course, we would give magnesium supplements. But you would know if patients with low magnesium, they would have symptoms of tiredness, fatigue, muscle cramps, twitching of the muscle, abnormal sensation in the muscle. These are all some of the symptoms of low magnesium, nausea, vomiting, all of these things.
All right.
And yes, if you get that, I will normally check your magnesium level and then give you supplements.
Great. Now, this question, while all our questions here has to be treated seriously, this one here got me a little concerned. I have this friend who suffers from high blood pressure, and she complains of a headache. Now she says that when she gets up in the morning, she does be spitting blood. Well, I'm concerned about this one, Doc.
Of course. You're concerned, but if we talk about cause effect, right? And there is something, a direct effect and an indirect effect, right?
Right.
If you get something in the brain, let's say I have a bleeding in my brain or a brain tumor, I wouldn't be if I'm spitting blood, where is that blood coming from?
That's right, it's coming from,
our mouth.
That's right, yeah.
Anus is a tract.
Yes.
Right? The brain, how the brain gets into the mouth, it can't get into the mouth.
Yeah.
So that headache that is happening in the brain, but I'll tell you the link.
Yes.
So it's not a direct, but an indirect effect.
Okay.
So the mouth is one, but the mouth is also connected to the nose.
Yes.
And the nose, the sinuses, the nose itself, and that is connected to, you have layers and partitions to the brain.
Yes.
So, but of course, the brain is sealed in a covering.
Yeah.
So that don't get into the mouth. But the nose gets into the mouth, the respiratory tract, where your lungs and that can come up into your throat. So your digestive tract, your respiratory tract, and your sinuses. So if somebody spit blood, the common thing that you're going to ask yourself, where is this blood coming from? Because you have to account it coming from the mouth, but the mouth is connected to the nose from your sinuses and the top part, and then the mouth is connected to your stomach, and then the mouth is connected to your breathing.
Right.
So the blood can come from those areas.
Yes.
But how do we relate that with a headache? Well, I wouldn't say you've got something in the lung. Yes, if you're really unwell, anything can cause a headache. We establish that. But what I think in this patient, to be honest, I think that this patient has got high blood pressure. Did they say something about blood pressure?
Yes, they did. Yes. I have this friend who suffers from high blood pressure, and she complains of a headache. Now she said that when she gets up in the morning, she spits blood.
Right. So I mean, if I were to just listen to that story and put money in it and say, what's my first guess there?
Yeah.
I think that patient, you know what they say, when your blood pressure is high, you get nosebleeds?
Yes.
So the common thing there is that pressure is probably high. It causes increased nosebleeds. And you have what we call anterior nosebleed and posterior nosebleed. Anterior nosebleed bleeds downward.
Yes.
Posterior nosebleed bleeds back of the nose, and you swallow it.
Okay.
And you spit blood.
Right.
So one of the things in spitting blood in the morning, patients would come to me and they would say, Doc, I spit blood and I don't have any chest symptom. Because blood is a serious thing. You spit blood, we want to know if you have TB, if you have cancer of the lung, or if you have an ulcer in your stomach and all of that, right? But the sinus and the nose itself, nosebleed, can cause you to spit blood. So maybe that patient blood pressure is too high, cause increase vascularity or pressure. The blood vessel is at a higher pressure, so it can burst a blood vessel. Like when you pressure high, you can burst a blood vessel in the eye, in the nose. That then can be manifested as spitting of blood. But that would be the most common explanation to me. But of course, I would want to know if your pressure is high also, you can have a brain tumor if you get headache associated with it. Because if there's a tumor in the brain, it increases the brain is a closed cavity. If you have a tumor in the brain, it increases, put pressure where the intracranial pressure gets high, the pressure in the brain itself gets high. Now the body has to produce a higher pressure to circulate, to allow the blood to circulate. We have to counteract the resistance of the brain. And in so doing, so that can cause your pressure to go up. But generally, when you check the pulse gets low, the pressure goes high. Those are signs of raised intracranial pressure.
Okay,
so
great.
We don't want to go and have things. But if it's purely due to high blood pressure, it may just be that this person has got uncontrolled high blood pressure, and they just need to control the blood pressure. Then I would want to put a camera, if I can't find a respiratory cause or a gastrointestinal cause like peptic ulcer, I would want to put a camera into the nostril to have a look if there's nosebleeds there. And that's what probably I would look for.
Thank you, sir. Thank you, Dr. Saw. Doc, what do you call the headache which feels like your forehead is plunging into your eyes?
I mean, I described, so lots of the headache, so I think that's a primary headache disorder.
Yeah.
Now, lots of the headaches will give you eye symptoms. We talk about that. But the one that is so descriptive of the eye, that makes your eye watery, red, you got a runny nose, and it's like piercing you, that's cluster headache.
Cluster, that's right.
Cluster headache does that. I described that in last week when I talk about headache. I say, oh my, I thought I was going to read this thing about the description of cluster headache. It is so well written, actually. I wanted to read that little verse, how a patient described their cluster headache. And that's the one that pierces you through and give you all these items. So I think that is a cluster headache they're describing there.
Okay, great.
Tension headache can give that a little. Migraine can also do that. But the most severe one is a cluster. Yeah.
Okay, good. Thanks. Doc, why are headaches so severe during menopause?
I mean, menopause is where you have chemical changes in your body, hormonal changes in your body, changes your chemical, and of course that can trigger, because we know that headache is a chemical type of disorder. So that can be either you can have more a primary type of headache, or it can be a secondary headache from other causes because of low hormone and all of that.
Okay, great. Next one here is...
It is more common, however, in premenopausal, as in period time, premenstrual type of headache. So you have more migraine trigger menstruation time than menopause time. Okay,
great. This next question is, a hangover due to alcohol intake, is it primary or secondary? You know, you get their headaches that are caused. Yeah, men, I can remember some man said, I feel like somebody beat me with a 4x4 in my head whole day. You know, that's how you wake up next day feeling, right?
That's correct. So that is a secondary headache. So primary headache is it's not something else causing it. But if you drink alcohol and you get hangover, we know the alcohol is the cause.
Right.
So something else causes it. So that's the definition of secondary headache. Now, the mechanism of hangover headache is multifactorial. There's no one cause of that type of headache. It's a combination of things. They say when you drink alcohol, it increases the sensitivity of these receptors in the brain. The alcohol can also cause electrolyte imbalance. We know that. You get dehydrated. It changes the electrolyte. It changes a chemical in the brain as well. All these, chemical and electrolytes and all of this can be affected. And that's the theory behind hangover. And that's why it's not so easy to manage, really.
Yeah.
Drinking too much.
This question here, I think we had covered it last week when the person was asking, good evening all, Doc, can you please speak on shocking kind of headache, which is the thunderclap? I think we spoke quite a bit.
The thunderclap one is that increased intensity right away. Yeah. But I think what this person is alluding to is not that thunderclap headache. So the thunderclap headache, this is a sharp shooting pain. Like you hit your elbow.
Yes.
And you get a shocking pain. You can get a similar type of headache. It's called trigeminal neuralgia. So the nerve that comes out is a nerve from the brain called the trigeminal nerve. And it supplies the face. It's divided into branches. You have ophthalmic branch, maxillary branch, mandibular branch. You can get sensitivity of those nerves where it gives sharp shooting pain.
Right.
And these pain lasts from seconds to minutes. And you can get tons of it. 20, 30 pain, sharp shooting pain per day. Or it can just be a few. And that condition is called trigeminal neuralgia. Now, lots of the time, we don't know the exact cause of it. There are lots of theories behind it. So they can be external causes where they say the nerve comes out from the brain, and it's got some opening in the skull that it passes through and it supplies different parts. And sometimes you have a vascular malformation where a blood vessel gets tortuous or get surrounded the nerve, and that can cause some pressure on the nerve, stimulate the nerve. So that's a theory, that one of the causes. Lots of times they say it's idiopathic, nobody knows. And then, of course, you can have bony fragments or some tightening of the nerve caused by other factors. But that is called trigeminal neuralgia, and we manage that differently. We use carbamazepine, anti-epileptic drug as well, can be used for them. And, it's a condition, classically, the patient will tell you, and, you can figure it out by the history alone.
Okay, great. Doc, what about if I have a headache at the back of my head? My migraine headache lasts for 1 week. What do I have to do to stop it?
So maybe that's chronic migraine. So I would say to that patient, so we talk about acute management, so you want to abort the headache. And the thing about aborting the headache, they say the earlier you start your painkiller, it's better. You don't wait to say, let me see how this headache is going to pan out. You know you're getting this recurrent. So if you have one headache where that headache stays in the back of your head for a whole week, and this is the first time you're having headache, you should see the doctor to rule out other causes. But if I'm having recurrent headache, so the definition of migraine is recurrent episodes of headache. So if this person's having headache, but their headache usually lasts for a week, then of course I would want to see, is this now considered chronic headache? So you can have chronic headache so lots of times patients end up using lots of tablets, pain-killing tablets. They say if you have to take more than 2 dosage more than 2 days of painkillers for migraine, that can give rise to chronic migraine, or what we call analgesic overuse, medication overuse headache. There's a condition called medication overuse headache.
Okay.
And too much of painkiller can give rise to that.
Wow.
So we are very skeptical about that you don't overuse your painkiller. If you feel that this headache is not going away, maybe that person needs specific drug, like the triptans we talk about, the G-pants. So these are specific drugs, and lots of time they would abort a headache.
Okay, great. Can weather changes causes headache?
Yeah, so that will be a trigger. So we talk about weather, we talk about stress, we talk about exercise, certain food. They are called triggers. So anything can trigger a migraine or a headache generally.
Okay, great. This question here, Doc, does gay men get anal UTI? But I think this probably was asked about STI.
Yeah, well, I think the question, what they wanted to ask maybe, is that if UTI, the bug that causes UTI, well, UTI means urinary tract infection. Right. So if you're having anal intercourse, I mean, there's not urinary tract that is except for the penis. It's part of the urinary tract, the urethra, that part of the urinary tract. So yes, you probably can be more prone. We have established that the bug that causes urinary tract infection can move from the anus into the urinary system. So by having anal intercourse, you can get there are more bacteria in the fecal, around the fecal matter and in the anus. So those bacteria can get into the urinary tract in that way. So it's one of these mechanical things that can give rise to movement of the bacteria into the urinary tract.
Right. Last question. What about when you get migraine headache and your head swells?
All right, good one. I mean, the thing is, the perception of your head swelling is, I would imagine, is a pressure of your head being heavy, feels swollen. I mean, it's hard for you to visualize, actually, to say, okay, I've got migraine, because migraine occur internally in the brain, and you get a skull and stuff. So I wouldn't expect this skull to just get bigger or outside of the parts to be swollen. But here's the thing. There are a couple of times that when you're under stress and you have headache or migraine, the muscles get a little bit more pronounced. So if my muscles tense, what happened? They look a little bit exaggerated. So, and then of course you can have some form of like in the type of migraine that gives you eye symptoms. The eye can get swollen and because what you have increased blood flow. The blood vessels expand and they just, they give you that increased pressure. So you can have some degree of probably facial or head swelling, but not so significant that people, I think in majority of cases, no. But the feeling of the head being swollen or bigger might be there. But I don't expect to see any gross physical swelling. Okay.
All right, great. Doc, that's our time for tonight also. Viewers, thank you so much for joining us tonight. I hope that tonight's information would have been good for you and share it with somebody whom you know suffering from migraines, or even if you're not suffering from migraines, it's good for information for everybody to know about these things. We want to myself and Dr. SAWH, we want to thank you so much again for all your contributions that you've been making towards this show in terms of asking questions and being here with us. So thank you so much for joining us. Doc, anything you want to say in closing?
No, again, thank you and your team again for doing this. And I think we, of course, we're trying to reach out to the public and to do some public education. And we want to promote this as much as we can.
Right.
And thanks to viewers for tuning in. Share it with friends and family. Yeah.
Right. So very soon, Doc and I, we are talking, and we're hoping to get this show also on local television stations, especially in Berbice and Essequibo. So we will be working towards that. At least this first segment where we talk about where's the education information segment. So again, viewers, thank you so much for joining us. Again, you know, my plea is always to slow down, take your time. We've had too many accidents recently, and stay healthy. We'll see you next week, where we'll be taking your questions from this week, and we're going to be dealing with another topic. So have a safe one and a healthy week so far.